If you're over 70 and your doctor just applauded bringing your blood pressure down to 120/80, you need to hear this. A study published in the Journal of the American Medical Association followed more than 15,000 older adults over a 5-year period, and their findings run counter to everything we've been taught about blood pressure goals. The seniors who achieved so-called ideal blood pressure had a 28% greater risk of serious falls, and their death rates were actually worse than those with moderately elevated numbers. Over the next 15 minutes, I'm going to walk you through the precise blood pressure range linked to the longest survival in older adults, explain why the conventional target may become hazardous after age 75, and teach you one straightforward test you can perform at home tonight that could prevent a devastating fall. My name is Dr. Dan Carter, and this information could genuinely save your life, or the life of someone you love. Before we go any further, drop a comment right now with just your age, nothing else. I want to see who's watching, because what I'm about to share applies differently depending on whether you're 65, 75, or 85. And if you've ever felt lightheaded when rising from a chair or climbing out of bed, add the word dizzy to your comment. This is crucial information I need to see, and you'll understand why in about 3 minutes. Here's what's taking place in doctors' offices across the country right now. A 78-year-old arrives for a checkup. Blood pressure reads 145/86. The doctor pulls up the standard guidelines, sees the target of under 130 systolic, and immediately reaches for the prescription pad. One medication is added, then another. Over the following 6 months, that blood pressure comes down beautifully, 124/78. The doctor is satisfied. The patient earns a gold star on their chart. Everyone considers this a success. But here's what the guidelines fail to account for. That same 78-year-old now gets up to use the bathroom at 2 in the morning, and their blood pressure plunges from 124/78 down to 88/56 within seconds. Their brain isn't receiving adequate blood flow. The room spins. They reach for the wall and miss. And suddenly, we're no longer discussing blood pressure numbers. We're talking about a fractured hip, emergency surgery, 3 weeks in rehabilitation, and a chain of complications that too often culminates in loss of independence, or worse. The research published just months ago in JAMA Internal Medicine should have been front-page news everywhere. But most physicians still haven't encountered it. Most patients certainly haven't heard about it. And that gap between what the evidence reveals and what happens in everyday medical practice is costing lives. Here's the part that's going to sound counterintuitive, and I need you to stay with me because this is where everything shifts. For decades, the message has been simple. Lower blood pressure equals better health outcomes. And for middle-aged adults, people in their 40s and 50s, that's broadly accurate. Controlling blood pressure in midlife prevents heart attacks, strokes, and kidney disease down the line. The evidence behind that is ironclad. But something fundamental changes after age 75. The research indicates that seniors with systolic blood pressure between 130 and 145 actually outlive those with pressure below 120. They experience fewer falls, fewer fractures, fewer hospitalizations, and sharper cognitive function. The group that hit that textbook ideal 120/80, they had elevated rates of dizziness, syncope, the medical term for fainting, acute kidney injury, and yes, higher death rates. Now, if you're someone who values understanding the reasoning behind the numbers, rather than simply being told what to do, what I'm about to explain will give you an entirely different lens for thinking about blood pressure management as you age. Your cardiovascular system at 75 isn't merely an older edition of your cardiovascular system at 45. It's fundamentally different in ways that alter what blood pressure figures mean for your well-being. Let me walk you through the 3 pivotal changes that occur with aging and why these changes call for different blood pressure targets. The first is arterial stiffness. As you age, your arteries lose their elasticity. Think of a brand new garden hose compared to one that's been baking in the sun for 2 decades. The weathered hose is rigid, less pliable. Your arteries undergo a comparable transformation called arteriosclerosis. When your heart pushes blood into stiffened arteries, they can't stretch and absorb the pressure wave the way young, supple arteries can. This means you need a somewhat higher baseline pressure to guarantee sufficient blood flow reaches your brain and kidneys, especially when you're upright and blood must travel against gravity. The second change involves baroreceptor function. Baroreceptors are tiny sensors embedded in your blood vessels that detect pressure shifts and instantly signal your brain to compensate. When a younger person stands up, their baroreceptors register the pressure drop within milliseconds and trigger corrective responses. The heart rate quickens, blood vessels tighten, and pressure stabilizes. But these baroreceptors grow less responsive with age. Their reactions slow down. So if your baseline blood pressure is already on the low side and your baroreceptors are sluggish, you experience that perilous pressure drop upon standing, a condition called orthostatic hypotension. The third change relates to medication metabolism. Your kidneys and liver don't process drugs as efficiently at 75 as they did at 45. A dose of blood pressure medication that's perfectly suitable for a middle-aged person can be excessive for an older adult. The medication persists in your system longer, exerts a stronger effect, and can drive blood pressure to dangerously low levels. Now let me tell you precisely what this recent research uncovered, because the specifics matter. The study published in JAMA Internal Medicine tracked 15,342 adults over the age of 75 for an average of 5 years. These weren't carefully selected healthy seniors. These were real-world older adults, including those with diabetes, prior strokes, heart disease, and varying degrees of frailty. The researchers recorded their average blood pressure and then monitored outcomes over those 5 years. Participants were sorted into groups based on systolic blood pressure. One group maintained pressure below 120, another fell between 120 and 130, another between 130 and 140, another between 140 and 150, and another above 150. Here's what emerged. The lowest death rate belonged to the group with systolic pressure between 130 and 140. Not below 120, not the textbook perfect figure, the moderate range. Those with pressure below 120 faced a 28% greater risk of serious falls requiring hospitalization. They showed higher rates of acute kidney injury, meaning their kidneys couldn't function properly under the lower pressure. And their overall death rate was 14% higher than those in the 130 to 140 bracket. The group with pressure above 150 also ran into trouble, as you'd expect. Higher stroke rates, more cardiovascular events. But the revelation was that very low pressure proved just as hazardous as very high pressure. The optimal zone, the range tied to the longest survival and the best quality of life, was higher than conventional guidelines advise. Let me paint a scenario so you can see how this unfolds in everyday life. You're 76 years old. You walk into your doctor's office for a routine visit. Your blood pressure reads 142/84. Your doctor looks concerned, consults the guidelines, and says, "We need to bring this down to at least 130, ideally closer to 120. You're started on a medication. 2 months later, your pressure is 128/78. Your doctor is pleased but suggests adding a second medication to nudge it a bit lower. Another 2 months pass. Your pressure now sits at 122/76. Perfect, your doctor declares. You feel fine initially, but then you start noticing something. When you rise from your chair to answer the phone, you feel a brief wave of lightheadedness. When you stand from the dinner table, there's a fleeting instant where the room seems to tilt. You mention this to your doctor, who tells you it's probably just age-related. Your blood vessels adjusting more slowly. Just rise gradually, take your time. But what's actually happening is that your blood pressure, which looks textbook ideal while you're sitting still in the office, is plummeting when you stand. From 122/76 seated to perhaps 95/60 upright. Your brain is enduring repeated episodes of insufficient blood flow. You're at serious risk for a fall, but nobody's checking for this because your seated reading looks flawless. This scenario repeats itself thousands of times daily across the country, and it's preventable. If we recognize that blood pressure targets need to be tailored to age and functional status rather than applied uniformly. Here's what astonishes me. There's a simple test that takes roughly 3 minutes and can reveal whether your blood pressure medications are placing you at risk for falls. It's called orthostatic vital sign measurement, and most physicians aren't performing it as a matter of routine. Let me teach you how to conduct this test at home tonight, because this knowledge could be life-saving. You'll need a home blood pressure monitor, available at any pharmacy for around $30. Here's the procedure. Lie down flat on your bed or couch for 5 minutes. Simply rest. After 5 minutes, take your blood pressure while still lying down. Record both numbers, systolic and diastolic. Now stand up and immediately take your blood pressure again while upright. Don't wait. Measure right away. Record those numbers. Now compare them. If your systolic reading dropped by more than 20 points, or your diastolic dropped by more than 10, you have orthostatic hypotension. This is a warning sign. It means your blood pressure medications may be too potent for you, or your target pressure may be too low for your physiology. Even if your seated or recumbent blood pressure looks ideal by conventional standards, if it's falling that dramatically when you stand, you face heightened risk for falls. Let me put specific numbers to it. Suppose your lying blood pressure is 125/78. Looks excellent on paper. But when you stand, it drops to 98/64. That's a 27-point systolic decline. That's dangerous. Your brain is receiving inadequate blood flow when you're upright, which accounts for most of your waking hours. You might feel perfectly fine while lying down or sitting, but when you're vertical, you're operating on insufficient pressure. This is the test your doctor should be performing at every appointment if you're over 70 and taking blood pressure medications. If they're not doing it, you can do it yourself and bring the results to your next visit. So what should your blood pressure actually be? I'm going to share the ranges that research associates with the best outcomes for different age brackets. But I need you to understand these are guidelines, not ironclad rules. Your individual target should be established collaboratively with your doctor, based on your complete medical profile. For adults aged 65 to 74, who are generally healthy and active with no major medical issues, research suggests a systolic range of 130 to 140 is reasonable. This delivers cardiovascular protection while maintaining adequate blood delivery to your organs. For adults aged 75 to 84 who are relatively healthy, the evidence supports a systolic range of 135 to 145. Notice this is higher than the younger bracket, accounting for greater arterial stiffness and slower baroreceptor responses. For adults over 85, or for anyone who is frail regardless of age, a systolic range of 140 to 150 may be most appropriate. At this stage, preventing falls and preserving quality of life often outweighs the benefits of aggressive blood pressure reduction. What about the diastolic number, the bottom figure? For older adults, diastolic pressure should generally remain above 65, ideally between 70 and 85. Very low diastolic pressure reduces blood flow to the heart muscle during its resting phase and can create problems. If your diastolic consistently reads below 60, that warrants a conversation with your doctor, even if the systolic looks fine. What about a 73-year-old with type 2 diabetes and one heart attack 5 years in the past? Their blood pressure sits at 148/86. Should they aim for 120/80? Probably not. Should they shoot for 150/90? Also probably not. For someone in this situation, research suggests a target of roughly 130 to 135 systolic might be ideal, low enough to offer cardiovascular protection given the diabetes and cardiac history, but not so low as to invite orthostatic hypotension and falls. The crucial point is that this target should be reached gradually, with attentive monitoring for side effects each time a medication is adjusted. Orthostatic blood pressure should be assessed. Symptoms need evaluation: dizziness, fatigue, mental fogginess. These may signal that pressure is being driven down too aggressively, even if the numbers appear satisfactory on paper. And here's something most people don't realize. Blood pressure fluctuates throughout the day. A single reading of 148/86 doesn't mean your pressure is permanently at that level. It might be 132/78 in the morning and 145/84 in the evening. What matters is the average over time. That's why home blood pressure monitoring is so valuable. It paints a far more accurate portrait of your true average pressure than sporadic office readings. You might be asking why, if this research exists, your doctor hasn't brought it up. Why aren't blood pressure guidelines for seniors different? The answer is complex, but it ultimately comes down to the glacial pace of medical practice change and how guidelines are developed. Most blood pressure guidelines rest on large clinical trials conducted over many years. The landmark studies that established 120/80 as the gold standard were carried out predominantly with middle-aged adults. When those results emerged, the guidelines were applied broadly across every age group. There was an implicit assumption that what benefits a 50-year-old must also benefit an 80-year-old. But over the past decade, researchers have begun examining older populations specifically, and they're discovering that a single standard doesn't serve everyone well. The difficulty is that it takes years for fresh research to permeate clinical guidelines, and even longer for those updated guidelines to reshape daily practice. Many doctors are still working from recommendations published 5 or 10 years ago. They haven't encountered the recent evidence suggesting that moderate blood pressure elevation is actually safer for very elderly adults. There's also a psychological dimension. For decades, physicians have been trained to believe that lowering blood pressure saves lives. That message has been reinforced constantly. It's difficult to pivot from that mindset to a more nuanced perspective that says sometimes moderate elevation is acceptable, sometimes even preferable. It demands that doctors think critically about each individual patient rather than applying a blanket target. And in our current healthcare environment, where doctors have roughly 15 minutes per patient, that personalized approach is genuinely challenging. Let me illustrate just how different two people of the same age can be. Both are 81 years old, but their circumstances couldn't be more distinct. The first person is living independently, getting by reasonably well overall, but managing several chronic conditions: mild heart failure, stage 3 chronic kidney disease, osteoarthritis. Their blood pressure is 158/88. The doctor wants to initiate aggressive treatment to push it below 130. The second person is also 81, but they're healthy, active, play golf twice a week, with no significant medical problems. Their blood pressure is also 158/88. Same reading, same age, but entirely different risk profiles. For the first individual with multiple conditions, layering on several blood pressure medications carries substantial risks. Those drugs could lower pressure too drastically, particularly upon standing. They could worsen kidney function. They could trigger dizziness and raise fall risk, which, combined with osteoarthritis, could be catastrophic. A more sensible approach might begin with lifestyle modifications. Then, if medications prove necessary, a conservative dose of a single drug with careful monitoring, accepting a target of perhaps 140 to 145 systolic, rather than pushing aggressively toward 130. For the second individual, the healthy 81-year-old, 158/88 might merit attention, but again, not aggressive intervention. Perhaps lifestyle adjustments alone could bring it down to 145/84, which for a healthy person at that age might be perfectly acceptable without any medication. Same numbers, different people, different strategies. This is what it means to treat the patient, not the number. Let me give you specific, concrete steps you can put into action starting tonight. First, if you're over 70 and taking blood pressure medications, buy a home blood pressure monitor if you don't already own one. Take your pressure at the same time each day for 2 weeks, morning and evening. Maintain a written log. This provides an accurate average and helps you identify patterns. Second, perform the orthostatic blood pressure test I described earlier. Lie down for 5 minutes, measure your pressure, then stand and measure immediately. If you see a drop of more than 20 points systolic or 10 points diastolic, note it down to bring up with your doctor. Third, evaluate your symptoms honestly. Are you experiencing lightheadedness when you stand? Unexplained tiredness? Trouble concentrating? These could be indications that your blood pressure is running too low, even if the readings look fine on paper. Fourth, book an appointment with your doctor specifically to discuss your blood pressure targets. Don't simply accept a blanket declaration that you need to reach 120/80. Ask what target is appropriate given your age, your other health conditions, and your functional capabilities. Bring your home monitoring log. Bring your orthostatic measurements if you detected a significant drop. Engage in an informed discussion. Fifth, if you're suffering side effects from blood pressure medications, speak up. Don't endure them silently. Many people assume that feeling dizzy or drained on medications is simply something they must accept. But frequently, doses can be recalibrated, medications can be swapped, or targets can be modified to enhance your quality of life while still delivering cardiovascular protection. Here's what you now understand that most people, including many healthcare providers, don't fully grasp. Blood pressure targets shouldn't be one size fits all. A 45-year-old and an 85-year-old should not be held to the same benchmark. For older adults, particularly those over 75, systolic blood pressure in the 130 to 145 range is linked to the longest survival and the greatest quality of life. Dropping below 120 raises the risk of falls, orthostatic hypotension, kidney injury, and potentially cognitive decline. Rising above 150 elevates cardiovascular risk. The safest zone lies in between. You've learned that orthostatic hypotension, that blood pressure drop when you stand, is frequently more dangerous than moderately elevated seated blood pressure. You've learned how to check for it at home. You've learned the physiological reasons seniors require different targets: arterial stiffness, diminished baroreceptor sensitivity, altered drug metabolism. Most importantly, you now possess the vocabulary and the understanding to have a meaningful conversation with your doctor. You're not merely a passive recipient of medical instructions. You're an informed partner in your own care. And that's empowering. You're now better educated about blood pressure management in older adults than probably 90% of people your age. You appreciate the nuance. You recognize that one approach doesn't suit everyone. If this information brought you clarity, if it addressed questions that had been lingering in your mind, if it gave you confidence to speak up for yourself, then I've accomplished what I set out to do. Drop a comment right now saying "informed" if you feel better prepared to discuss this with your doctor. Share this video with friends or family members over 65 who might benefit from this knowledge. And subscribe to this channel because my mission is delivering research-grounded health information that's accessible, practical, and potentially life-changing. I'm Dr. Dan Carter. Take care of yourselves. I'll see you in the next one.